Thank you. I've got the longest title in the world just to make it complicated, I know. So, you know what to do. I work in Bristol at UHBW, and for the last 3 years, as part of a Southwest regional project, I've been setting up the radiotherapy late effects service. But today I'm going to cover radiotherapy a little bit, but I'm also going to talk about all modalities of cancer treatment, so chemotherapy and surgery, because late effects are a group of things that I'm learning can affect any part of the body. I don't just deal with sarcoma, I deal with every cancer type. So, but for your benefit, actually the late effects often are very similar. So what are late effects? I don't want you to be scared, I'm not trying to frighten you. I'm trying to give you some information and empower you to understand what could happen in the future after your treatment, so that you have some knowledge to go forward and tell people what you need help with. So we often have acute side effects caused by treatment, and those are the things that you go through whilst you're having treatment. And then the long-term or late effects, which is what I primarily deal with, are things that can happen anything 6 months to 20 or 30 years after you've had treatment. Macmillan in 2013, and many people have quoted the same since, said that cancer and its treatment often leaves a grueling physical and mental legacy for years afterwards. And for everyone that's come to see me at my service, and I've had 400 referrals in the last 2 years, I would say this is definitely true. So let's talk about radiotherapy and why you might get late effects. So we don't know exactly why radiotherapy causes late effects, but it's a very specific targeted treatment, and we only treat a very specific area. So we do know that when we give radiotherapy, we damage cells, and this is what we want to do, because we know that cancer cells don't have the ability to repair nearly as well as normal tissue cells. So hopefully what we do is we kill off the cancer cells, and your normal tissues heal and repair, and they go on working normally. Unfortunately, and if you think about, and I use this analogy a lot, the difference between a cooked sausage and a raw sausage, actually after we've cooked that sausage, it's probably never going to go back to being the same as it was as a raw sausage. And I kind of think radiotherapy is a bit like that. So sometimes the tissue does change. Doesn't change completely, it still might function, it still looks very much like a sausage, but actually inside things can be a little bit cooked, a little bit stiffer, maybe not quite as stretchy as it was before. There is no conclusive test for whether, if we did a biopsy or we sampled it, and probably my pathologist friend here it's very hard to diagnose fibrotic tissue. So even if we scan you, we look at it, we can say, oh, we think that is radiation-induced fibrosis. But actually, do we want to do another operation? Do we want to take a sample? The chances are if we did, we'd do more damage than good, and it actually wouldn't tell us much, or are we going to do anything about it? So I think a lot of our assumptions about radiotherapy damage are done a bit on diagnostic imaging, so the MRIs, the CTs that you have, and some tissue sampling, but mostly it's about an assumption. It's about a function. The tissue's not functioning like it used to before, and we think that's probably due to the radiotherapy. I said radiotherapy is very specific, and we do only treat a small area that we want to treat. Unlike chemotherapy, where it affects your whole body, and you'll know this if you've been through it. It's not just one small area, but actually it batters you from top to toe. So again, whereas radiotherapy, I can look at the treatment plan and say, oh, we treated your leg, your arm, your shoulder, your stomach. Actually, with chemotherapy, it goes all over. So anything can be affected. So one of the main issues we have is establishing the cause of symptoms. Looking at our radiotherapy treatment plan, and someone already touched on this in our discussion, was about, do GPs know that I've even had treatment? And we are trying to get codes done better so that actually things are flagged up if you've had chemotherapy and radiotherapy. But one of the things we need to do is to arm you with the information to tell people what treatment that you've had. I particularly specialise in radiotherapy, so I will look at your treatment plan and tell you whether what you're experiencing actually could possibly be related to your radiotherapy. But we do as often people like to blame us for everything. Chemotherapy, they're not so quick to blame actually. Often people will present with symptoms but actually don't put it down to the fact that they've had some really quite nasty drugs. And actually this could cause long-term side effects. So again, it's about looking at what are the possibilities. Surgery isn't without its complications. And again, we cause a lot of scar tissue when people have surgery. If you have chemotherapy before or after, radiotherapy before and after, the combination of the radiotherapy, the chemotherapy and the surgery can cause all sorts of issues. So these are the things that we're dealing with. And again, I'm not trying to frighten you. I'm just trying to tell you that if 10 years down the line you start to have problems, don't discount the fact it was that horrific chemotherapy or radiotherapy or surgery that you had 10 years ago. The other thing is that we naturally age, so things start going wrong anyway. It might be nothing to do with your cancer treatment. It might just be that that's what's happening. So sometimes talking to your friends and they start getting up twice in the night to go to the toilet, actually that's really normal, but it could also be something to do with the treatment you've had. So don't discount it, but also bear in mind it might not be related. And the other thing that I want to bring up, and I always hammer home, is cancer-related fatigue is real, really real. So not just 1 month, 2 months, 3 months, 6 months after treatment, but 1 year, 2 years, 3 years post-treatment. Sometimes it never goes away, and so often you need support with this, and there is help out there. So I've broken it down into little bits of body, and I'm not going to go through all of them step by step, but things to look out for. So both radiotherapy of the pelvis, so anywhere below your waist to the top of your legs, can cause problems with your bladder if it happens to get in the way. Chemotherapy also is really toxic to your bladder. Your kidneys filter it and then it sits in your bladder and then you have to get rid of it. So there's always going to be some damage that can be done on the way through. We minimise it and we know that normal tissues recover really well. But actually, if you start getting problems with incontinence or going to the toilet a lot, or you've got a problem with flow or burning, these are the things that please go and ask. Go and mention to your GP, oh, I had some radiotherapy to my pelvis. I had some radiotherapy to my tummy. I've had chemotherapy. Things like this. We want you to just bring it up. And so I suppose that's what I'm trying to do today, is say, these are the things that could happen, and these are the things you need to ask. There are some simple solutions. So for stress incontinence, so things when you jump up and down and cough and sneeze, we should all be doing our pelvic floor exercises. So it's little things you can do to help yourself. People think they don't work, but actually they don't work if you only do them once, maybe twice for a week. They do work if you do them every day, even a couple of times a day, for 6 months. And actually you'll start to notice the improvement. So again, it's just about little things that you can do to help, but it's also giving you things to go and ask about. Poo, we all look like talking about a bit of poo. So while we're on treatment, we get loads of problems with our bowels. And then after treatment, things tend to settle down. Now, we had a lovely talk this morning about microbiomes, and I'm all a big key on microbiomes. We know that radiotherapy and chemotherapy kills off a lot of those good bacteria. So the more good bacteria you can get back into your gut after treatment, the better. So a lot of people come, they're doing lots of little tiny poos all day. Really common if your microbiome isn't not great. They have bad wind, they get a lot of mucus, those kind of things. So those things get some good bacteria back in, and it can be something as simple as a probiotic drinky yogurt. Every day for a month, maybe 2, just to try and get some good bacteria back. Fibre, we love fibre. But again, it's trying to increase your soluble fibre. So look up what is soluble fibre, and then things like adding in a bit of milled or golden linseed into your breakfast cereal in the morning can be great. There are things like fibre gel, Normacol, easy ways that you can get on prescription to bulk your fibre up, but it just slows your gut down a bit. We've irritated it with lots of nasty chemicals and lots of x-rays. It might not be very happy. So again, people think a year down the line, oh, it should all be back to normal. But actually, if you've not given it any help to get back to normal, it might not be. So actually start getting some good bacteria back in there. Again, mention to your GP, actually, if you've got any kind of bleeding or anything like that, it could be that your gut's just really irritated. It could be something more sinister going on, we don't know. But they'll do a stool sample. But please just ask them. If you don't ask, they won't do anything. They're gatekeepers. They can't be a specialist in everything. So it's just worth asking. There is this really useful document, the PRDA Best Practice Pathway, which is an amazing document for anyone that's had pelvic radiotherapy, but in particular, it's really good. It covers every area of pelvic irradiation, but also lots of other little things that are in there. I'm going to cover a few more on the way through, but you can look that up. My slides are available at the end, so you don't need to remember. So head and neck. Again, don't underestimate the treatment. I mean, we know that chemotherapy as well as radiotherapy causes lots of problems with your mouth. You get dry mouth, you get thrush, you get ulcers, you get all these things. And it takes a long time for them to come back, get back to somewhere where they were before. We have a lot of little treatments that can help. Simple things like not swigging water but using a spray bottle instead, so that you're not washing your own natural saliva down, but by spraying it, you're just keeping a bit of liquid in your mouth. Oil pulling, I'm not really big on that myself, but it's where you put some olive oil in your mouth and you'll just hold it there for ages to try and stimulate your saliva. It's a bit gross, but if you want to do that, feel free. And then there are professionals out there. So again, we know sometimes that your mouth works fine for a couple of months, maybe 6 months, maybe a year after treatment. But then your swallow gets a bit rubbish and you don't know why it's happening. Well, often it's because the tissue's just changing a little bit. And if that's the case, go back, ask for some support, ask to see a speech and language therapist, ask someone to assess your swallow. I'm trying to give you the technique to go and tell people that you want help rather than expect people to give you help, because unless you ask, you won't necessarily get the help you need. Chemotherapy can cause long-term changes to your smell and your taste. And again, like the Royal National Institute for the Blind, they have a brilliant thing on how to stimulate your smell to encourage it to get better. They did a lot post-COVID, but things like that can really help with your taste. So there's little things that are available that might help. For skin, and I do see quite a few, probably my most common sarcoma people post-radiotherapy is skin that hasn't quite healed, or if it has healed, it looks very different. It's quite dry and flaky. Often people are sent to dermatology, they're given steroid cream. And although I'm not a big advocate for steroid creams because actually it has the opposite effect of thinning, it can be used short term. Actually, just a good treatment care regime is really important. So just washing, moisturising, not using soap, things like that is really important. Vaginal estrogen, if you can have it, is really good. Any kind of irradiated area in the soft tissue, but also chemotherapy dries out the mucosal linings, so that kind of thing can just long-term be really uncomfortable. So again, asking for water-based or moisturisers, or if you can have estrogen-based vaginal moisturisers, again, perfectly within your right to ask for them from your GP, but they won't necessarily think about giving them to you. Insufficiency fractures are very common, but not so common with radiotherapy, but caused by often high-dosed and concurrent chemotherapy. They're very tiny hair-like fractures caused by high-dose radiotherapy. You tend to get very acute sudden pain, and then it disappears, and you just get low-level dull ache. We obviously always worry if you've got a primary bone cancer that we would investigate anything, and all of these would, you know, anyone that presents with a insufficiency or sudden onset of bone pain, we will send for further investigations. But once everything's ruled out, or if they say that you've got an insufficiency fracture, then there's a few simple things that we can do. Sexual function is not something that people talk about very often, but it's a big part of cancer treatment. partly because you've been on a massive journey, partly because it's something that people don't talk about, and partly it's because how you feel about yourself can relate or reflect in your sexual function. So the basics of making sure that you haven't got soreness, that you can get an erection, that you are comfortable and happy in yourself to feel that you want to embark on it. The change in how you look or feel is really big thing. So again, please ask for help. There is a lot of help out there, but often as oncology professionals, we're not really very good at talking about it. I deal a lot with penile shrinkage for people that have had hormone therapy. You know, simple things like a vacuum pump to use as though you're going to the gym. It sounds a silly thing, but it's actually something you can do yourself, and it makes a really big difference. For ladies, there's loads of little tools that we can use. So O-nuts, which help with depth of penetration, dilators, vibrators, and this is the vacuum pump that I was talking about. If you're worried about sexual function, please ask, because someone will talk it through with you. It's up to you, but it's also up to us to bring it up. But please, please ask. There is help out there. So what I want you to take home today is think about what's really happening. Think about the issues that you might have that you want to ignore. They might not be related to cancer, and it might not be that you're worried about recurrence, but it might just be that something isn't like it was before and you want something to be done about it. Take these to your GP and ask them, please can you help me? Please can you find someone? Late effect services are few and far between. The radiotherapy late effect service in the Southwest, we're collecting a lot of data to prove it's needed, but what we need is an oncology late effect service really, covering all areas and modalities of treatment. Ask yourself and ask the professionals, could this be related to my cancer treatment? And if you don't get the answer you want, keep asking. If necessary, go back to where you had your original treatment and ask them. Ask your CNSs. They're really good at finding information. Thank you.